The next thing you do is you do the ACTH dose-entropin test and the aldosterone levels. You want to know now, okay, if I give them ACTH, what would happen? Well, I already know that's high, so that's probably not going to help me. So if I give them ACTH, it's probably not going to make a difference. The cortisol will probably not change or stay low. The other thing is if I check their aldosterone levels and it's primary, that means they're not producing aldosterone, and then subsequently the renin level should go up to try to increase aldosterone. All right, that's the case. It's definitely primary AI. Another thing is autoimmune. Is it TB? Is it Waterhouse-Friderichsen syndrome? Is it some type of infiltration by tumors? So check the 21 hydroxylase antibodies, right? See if there's
this. What I'm learning. This is the doctor stuff. Just saying.
Component here. Get an adrenal CT MRI. See if there's any infiltration of the.
Depending on how I feel, I may or may not go back to school to get my doctorate degree. I don't think that's a bad thing at all. I don't think about that. I'll think about that.
If there's any hemorrhage, potentially within inside of the adrenal cortex. Sometimes you can do a fine needle aspiration to definitely determine if it is tumor, if there's tuberculosis. And you can send off your basic tuberculosis tests, such as doing the TB skin test or the interferon testing and seeing if the patient has TB. All right. Now, we move to the next step here, which is how we treat adrenal insufficiency. You basically have, now, we move to the, here. Get an adrenal CT MRI, see if there's any infiltration of the tumor, if there's any hemorrhage, potentially within inside of the adrenal cortex. Sometimes you can do a fine needle aspiration to definitely determine if it is tumor, if there's tuberculosis. And you can send off your basic tuberculosis tests, such as doing the TB skin test or the interferon testing and seeing if the patient has TB. All right. Now, we move to the next step here, which is how we treat adrenal insufficiency. You basically got to replace the hormones that they're missing, right? That's the big thing. If you've destroyed the adrenal cortex, unfortunately, that damage has been done. You're not going to be able to do anything about it. You can try to prevent the recurrence by treating the underlying cause, but oftentimes it's replacing what the patient doesn't have. So in chronic adrenal insufficiency, the biggest thing is cortisol. And so in this particular scenario, you have to give them corticosteroids. But the corticosteroid choice really depends upon the scenario slightly. So this is somewhat of a kind of a particular point here. So how do I know which one do I give? Well, generally the corticosteroids are kind of dependent upon the scenario. So adrenal crisis, you need IV steroids, and usually the agent of choice here is hydrocortisone. And more of a unclear diagnosis, I don't really know if the patient has adrenal insufficiency and I'm treating them as such, and I need to send off labs like the cortisol labs and ACTH labs. There is one drug that has been shown that it doesn't really alter with your the potential ACTH dose-entropin test and your cortisol levels, and that is dexamethasone. And so that would be a potential indication if you don't know the diagnosis of adrenal insufficiency, you're working them up, but you're trying to treat them in the interim. And the last one is when you know the diagnosis and you're trying to treat them more in outpatient setting, they're not adrenal crisis, that would be usually something like prednisone. That's going to be the most common agent. So again, replace those particular agents. If the patient does have a depletion of aldosterone, they have hyponatremia, hyperkalemia, metabolic acidosis, a little orthostasis, fludrocortisone can literally replace aldosterone in that particular scenario. Adrenal crisis is a completely different story though. In this scenario, you gotta give them cortisol, but you gotta give it to them again in the form of the most quickest way possible to assume that they get every bit of it, and that's usually in the form of hydrocortisone. The other thing is in adrenal crisis, we're not gonna give them fludrocortisone. I'm just gonna do what fludrocortisone would do. And I'm gonna give them sodium, I'm gonna give them water. And so the other thing that I'm gonna do here is in this particular scenario, because of them not having enough of the sodium and water, I'm gonna give them IV fluids. The other thing is that these patients will be hypotensive, and it's because they have a deficiency in cortisol and a deficiency in aldosterone. So oftentimes it's important to put them on things like vasopressors like norepinephrine or phenylephrine to support their blood pressure. The last thing is that these patients will develop hypoglycemia. It's important to remember that this hypoglycemia should be closely monitored with continuous point of care glucose checks, and putting them oftentimes on an IV dextrose infusion may be necessary. Lastly, I think the biggest thing to remember for adrenal crisis, and this is something you'll definitely get on your exams, is that when a patient has adrenal crisis, oftentimes it's that you did not give them the adequate amount of steroids that they needed to have a good response to the stressors on the body. So in other words, if a patient has adrenal insufficiency chronic, they get an infection, put them on steroids. If they're going to get a surgical procedure, put them on steroids. If they suddenly discontinue them, put them back on their steroids. So you need to give them stress dose steroids during these periods where they have an infection, an illness, a surgical procedure, so that they are able to mount an adequate response to that the body's demands have. And that is important to preventing adrenal crisis. All right, my friends, that covers adrenal insufficiency.
Okay, so we finished the lecture on Addison's disease and Addison's crisis. So, with chronic adrenal insufficiency, all of it is adrenal insufficiency, okay? But if you have Addison's disease, this is chronic, okay?